So it is 6 o'clock, and so I have opened the waiting room and people are joining. I'm Barbara Lee Van Horsen. I am the experimenter at the Momentum Center, and I'm delighted that you're here tonight to participate in our winter series. The next 3 Tuesdays, we'll be bringing these presentations free to anybody who wants to attend. We kick off tonight, and I'll introduce Brett in a moment, but we'll be talking about depression and bipolar and mood disorders. Next week, we'll be talking about anxiety, panic, anxiety disorders. And then the third week, we'll be talking about schizophrenia. So really wonderful opportunity. We have amazing professionals who have volunteered their time to speak and to answer your questions. So as Brett Van Tol is our speaker tonight. Brett is a PhD psychologist from Pine Rest. He's spoken for us a number of times. He's always so helpful and informative. So as he speaks, if you have questions, please put them in the chat box and I will call his attention to those questions. And if you have any comments, please also share those. And with that, I will turn things over to you, Brett Van Tol.
Thank you, Barbara. It's good to be here, and it's good to be able to be a part of the Momentum Center's mission. And I'm looking forward to tonight. I'm looking forward to talking about tonight, especially kind of to get started, the mood disorders of depression and then also the bipolar mood disorders. So what I'd like to do tonight is just kind of give a brief overview of those particular sets of diagnoses that we have within the field of mental health. And really kind of have maybe a conversation or a discussion about depression, about mood disorders. I'd love to be able to kind of discuss in terms of any questions or comments that you may have. So I want to talk about sort of what the mood disorders are, how we diagnose them, kind of an interesting way, I think, of understanding them, understanding how they affect us. I often say this, right, is what does depression look like inside of us? Or what does a mood disorder look like inside of us? And that's some of what I want to be able to sort of share with you tonight, talk about tonight, and then maybe talk a bit too about how does depression, how do these mood disorders affect us, not just individually, but also maybe affect our families, who we are maybe as caregivers. And so maybe we can get into a little bit of talking about that as well. So let's see how this goes and if I can make this work. All right. So here are, this is kind of a continuum, if you will, of depression or of the mood disorders. And across the top, as you see, we have this continuum goes from severe depression to something called mania. And mania would be kind of a very exuberant level of energy, so much so that we're losing sort of normal everyday function. So this is kind of the continuum that we're thinking about when we think about a mood disorder. I'm going to talk first about sort of major depression, which is going to be that far left side, the blue side of your screen. And then we're going to talk a bit about a depression that's not so severe in intensity, but it's very chronic and long lasting. We call that a dysthymic, or nowadays it's called a persistent depression, persistent depressive disorder. And then we'll talk a little bit more about the right side of the continuum, about mania and what we would call hypomania, or another way to say that is maybe a half of a mania. And these mania and hypomania are what we think about when we start to diagnose bipolar type 1 and bipolar type 2. So we'll get into that as well. So in terms of that left side of the screen, in terms of major depressive disorder, just to give you a very kind of rough overview or quick overview, we're looking for like 5 of the following symptoms that are happening every day for about 2 weeks. And there's a list of sort of the symptoms that's found in what's called the Diagnostic and Statistical Manual, which is sort of our manual for the guidelines for how to make these different diagnoses. And you can think about this as, really severe depression would be, we would tend to see a lot of sort of this cognitive kind of symptoms. I'm going to click to the next slide here. So we're going to see a lot of the kind of, I'll start from the top, the physical symptoms, sleep changes, appetite changes, energy level changes, aches and pains, loss of libido, all these kind of physical symptoms that can go with depression. Then the emotional symptoms that we really tend to think about when we think about depression, that feeling sad, the emptiness, the hopelessness, the loss of interests. But then there's also the cognitive symptoms of depression or the thought symptoms. So here we get the negative view of self or the negative view of my environment around me or the negative view of the future. Aaron Beck, who was a behavioral psychologist, really took a look at, and he, along with some of the psychologists that came after him in the field of cognitive behavioral psychology, really started to outline for us exactly how depression affects the way we think about ourselves and about the world. And the way that we think, having those negative viewpoints, really can exacerbate or lengthen kind of our depressive experience or the experience that we have within depression. And we could talk some more about that. We call that kind of attributions, right? Attributions that I make about myself. If I have negative attributions about myself, it's really going to affect sort of my experience of depression. One way to think about that, like if I were to walk into a room that you were sitting and I tripped and I fell, I would have to explain to myself what just happened. And I could say to myself, wow, I'm a really clumsy person. I'm so clumsy. I just tripped walking into this room. And I'm interpreting what happened in a way that describes what happened as a very kind of negative quality about me. I'm a clumsy person. And that's a negative self-attribution. Other people might say, I walked into that room and I tripped because that room just wasn't designed very well. Somebody didn't lay the carpeting well. There was a step there when there shouldn't be a step there. And I can blame the fact that I tripped on something outside of me, some other part of the environment. And if I blame it on some other part of the environment, I'm not creating a negative attribution about myself. Now, the interesting thing about that in terms of depression is when we have a tendency to blame things on ourselves, we actually become more likely to develop depression. When we blame things on aspects that are outside of us, right, we're less likely to develop depression. And that same thing holds true for our negative attributions of our environment and our negative attributions of the future. So that kind of quickly is sort of the symptoms of depression. We'll talk more about depression in men and depression in women a little bit farther into the talk. But I want to kind of move on a bit again and go back to our continuum. And now I'm going to talk a little bit about what we would call a more chronic but less intense depression. We used to call it dysthymia, and now we call it that persistent depressive disorder. But that kind of persistent depression is where you have more days that you're feeling kind of down or depressed in a 2-year period than you do when you're feeling good, or the word we would use is euthymic, when you're feeling sort of normal, typical. So if you have more days that are depressed and that's lasted for 2 years, we start to call that a persistent depressive disorder. And here we want to see, in order to make the diagnosis, two of the following, right? Like that poor appetite or overeating, a sleep disturbance, low energy or fatigue, the low self-esteem, that can come from those negative attributions, and then difficulty with concentration, difficulty making decisions. And that's kind of a persistent or dysthymia, persistent disorder. It's interesting because that's a kind of depression that's very real. And often individuals are not seeking treatment for that. They're sort of learning to live within this depression. And many individuals who do eventually get treatment will say, I didn't even know that something better was possible. I just thought that that was the way life was. And that's that interesting thing about that persistent depression is that it can sort of become our norm, and we don't even know that there's something else beyond that. So now I want to move a little bit more over to the right side of the screen. You're looking at the orange side, and talk a little bit about mania. Mania is this condition that has to exist for 7 days in order for it to be a clinical kind of mania. And it's this period of very elevated, expansive or irritable mood that is so elevated that there's an impairment in functioning. There is a lot of times we almost in popular talk in the movies, or just the way we talk to each other, we sometimes use that word manic or mania, and it really doesn't get at what the clinical experience of mania is. That clinical experience of mania is a very grandiose or inflated self-esteem. And especially, we often see this decreased need for sleep. There's hardly any sleep. In fact, it's difficult to sleep when you're in a mania or a manic episode. Very much this kind of talkative, pressured speech. Individuals that are in a manic or more hypomanic, but especially a manic, now we're talking about episode, it's hard to interrupt them. Their thoughts are just racing. They can have an idea and believe that, this is the best thing and they have to do it. An example of this would be like an individual that I worked with once who had this idea of selling a certain kind of product to trucking companies because he was certain that this product was going to save them money in terms of diesel fuel and make their trucks last longer. And he was up, 20 hours a day. He was contacting all these different trucking companies. He had this belief that, he could sell this product to them, that it was very valuable to them. He bought a garage load of this product, spent a lot of his own savings to store it in his garage. He started driving around to different places to try to sell it. And nobody really was interested in this product, but he had this really grandiose idea that this was the best thing. And it started to create a drain on his family savings account. His family started to get very concerned for him. The more concerned other people were getting, the bigger this idea became for him. And he started interrupting people in their place of business. He started to get very pushy. He started to get angry and irritable when people didn't want to give him the time of day. And that's a kind of classic sort of manic episode. there's this real, again, kind of goal-directed activity, right? I can make a lot of money doing this. I can, and it gets very exaggerated. There can be a lot of risk taking when there is a mania. There can be a lot of impulsivity, and that impulsivity can go into the fields of alcohol, drug abuse. There can be hypersexuality, hypersexual kinds of behaviors, all driven by this immense amount of energy inside of a person. And that's, kind of a manic episode when it lasts for 7 days and it's impairing function. So now to go back again, that's that far right-hand side of this continuum. Now we're going to back towards the middle a little bit, and we're going to talk about a hypomania, or you could think about this as kind of a half a mania. So in a hypomania, we've got a distinct period of elevation, an expansive mood, maybe an irritable mood lasting for 4 days, but not necessarily impairing function. So a person can still kind of attend to their day-to-day responsibilities, but they do it with a lot of energy. And again, you can see a bit of an inflated self-esteem. You can see some decreased need for sleep. There can be a lot of ideas that kind of flood through this person. They can be kind of goal-directed, but it's all functional. These kind of individuals often make really, really good employees because they are so hardworking. They'll work extra hours. They're very goal-directed. However, the cost is that they tend to burn out. And also over time, they tend to start to irritate and rub others a bit the wrong way because nobody can kind of keep up with them. And they can get a bit distracted off the main focus. So somebody at work can get really, really excited and start doing something that's not that important. And they're really focused on it and pouring a lot of energy in it. And they can be really working hard at it, but it's just not that important. And it's kind of hard to bring them back. And because they're kind of going, they don't tend to listen or take instruction very well. Sometimes people with hypomania actually make really good salespeople, especially traveling salespeople. But it can be really hard on relationships. And that's in part where it really starts to then eventually impact functioning, is functioning in relationships. Now, let's talk a bit, before we move on, let's talk a bit about the bottom part of this slide. I want to talk about a bit the difference between bipolar 1 disorder and bipolar 2 disorder, kind of those green lines there at the bottom of the slide. This gets confusing sometimes because we often kind of think that bipolar 2 is maybe, something that is not quite as severe as a bipolar 1. And in a sense, that's true. But what happens when we diagnose bipolar 1 is if a person has ever in their life had a manic episode, so as we take their history and we go through the history of their life, if there's ever in their life been a manic episode, then they automatically get a bipolar type 1. So bipolar type 1 just means that at some point in your life, you had a manic episode, or we believe you had a manic episode. If, as we're working with a person and we take their history, we can't tell that they've ever had a full manic episode. They may have had hypomania, but they've never had a full manic episode. Then they get a bipolar type 2 diagnosis. So bipolar type 2 and bipolar type 1, bipolar means just kind of the way the name sounds, is this is a individual whose moods go back and forth from depression to high energy to depression to high energy. And how those moods cycle can be very different between people. Some people can be kind of high energy and have brief periods of depression. Some people can be very depressed, but have brief periods of high energy. So there can be differences that way. But in general, we diagnose bipolar type 1, we diagnose bipolar type 1 if there's ever been in the person's life a history of a full manic episode. And that's the key difference between the two. This gets kind of confusing because you'll hear sometimes psychologists, psychiatrists, other mental health professionals that talk about things like rapid cycling. And rapid cycling is, interesting in the sense that some people start to think, well, my mood can swing back and forth even within a day several times. And sort of the purest diagnostician who's diagnosing a mood disorder would not qualify for them in terms of the kind of mood disorders that we're talking about when we diagnose a bipolar mood disorder. Not this kind of rapid cycling where you're switching back and forth within a day or a couple of days. The caveat there is that there are people that have what we call mixed presentations, where they can have a depression and a mania that are kind of mixed together at the same time. So this does get confusing, and it gets a bit hard to diagnose sometimes. It's interesting because some research will show that the diagnosis of a mood disorder, especially a bipolar mood disorder, often takes several years before that mood disorder is really known and diagnosed with any level of certainty. It's not uncommon for us to have individuals who had mood swings that caused a lot of chaotic sort of behaviors in their teenage years, maybe early adult years, and the bipolar mood disorder isn't really identified or treated appropriately because it's not diagnosed, because it's really hard sometimes to figure out what's going on. You have sort of what we call that, normal teenage angst that is hard sometimes to kind of filter out. A diagnosis of ADHD, hyperactivity disorder, can often sort of get confused with this sometimes. Anger problems can get confused with this sometimes. And then the big one is substance abuse. Substance use makes it very difficult to really figure out if there's a mood disorder underneath that substance use or substance abuse. And that can take some time to really kind of figure out. So again, if there are some questions or comments about that, that's an area that we can talk a little bit further about. In the very middle of your screen is that green line called cyclothymia. And cyclothymia is this kind of up and down mood disorder that is, again, for somebody that's typically pretty functional from day to day, but they can have, this week or several weeks or month where they're kind of a lot of energy, and then they can have a period of time, again, maybe a couple of weeks or a month where they're just very depressed. And so they tend to have this cycle that goes up and down and up and down. That's not diagnosed very often because, again, these people tend to be pretty functional. They're not really seeking treatment because it's not so severe, but it can be a kind of cycle of moods that can be disruptive in their life, and particularly disruptive in their relationships. And again, if it's interesting because if a diagnosis can be made and a person is able to seek treatment and get treatment, many times what I hear from these individuals is, wow, life is so much easier than I ever knew it could be, right? It's so much smoother than I ever knew it could be. But again, it can be a cyclothymia or a persistent depressive disorder can become so normal for somebody that they can't really see that there's something different. Now, the other thing I want to sort of talk about quickly, and I don't have a slide here. I wish I had a slide, but I really want you to think about mood disorders almost as a color wheel, right? Or a color chart. And, if you had a color wheel and you had, the reds and the greens and the blues, and you had all these different shades, that's a lot of what our moods are like. We have all these different shades of moods. And as a psychologist or a psychiatrist or a therapist, I really need to be able to take a good history with a person to get a sense for what their different shades of moods have been. And it's these different shades of moods as they blend together and blur together that help to guide my understanding of what kind of mood disorder, if any, a person may be experiencing. And there can be at times some confusion in how these moods or how these colors blend together. Things are not always real clear or clean, in the real world as we would like. And we can create these different diagnostic categories, and we can have our rules for how to diagnose them. But everything doesn't always fit neatly into a diagnostic category or fit neatly into the rules. And so we do have to really have a sense for kind of this color wheel feel of moods, and an ability, knowing that, to kind of figure out what makes the most sense in terms of this person's symptom presentation, the symptoms of their mood and their presentation, what explains it the best. And I say all that to say that, professionals, right, psychiatrists and psychologists, don't always agree. Sometimes we tend to see a certain person just a little bit differently, based on our experience of that person, our knowledge of that person, the history that we've done with that person. And again, I think as a consumer of mental health services, that can be kind of confusing, right? We really like to say to ourselves, if I have depression, I want to know I have depression, and I want every doctor I go see say, yes, you've got this kind of depression. That especially gets true with bipolar 1 and bipolar 2 mood disorders. And it can be very confusing sometimes. So that's the reason, I think, for a lot of the confusion. And again, that may be an area that we can talk about a little bit further. I want to move on here to ask that question that I talked about at the beginning, which is, what does depression or what does mania look like inside of us? So here, here's a picture of kind of a brain inside a person. And we're going to focus the next part of our talk here kind of on the brain, and the brain as the organ in our body that is the organ that is the beginning of depression or mania. And we're going to talk about, what does this look like inside of us? What's going on in our brain? I'm going to try to talk about it in a fairly simple way. So I just give you this general caveat that what's really going on inside of us is way more complex than I'm going to talk about, but I think it helps to talk about it in kind of a simple way just to sort of understand. So I want you to think about your brain as filled with all these different neuronal pathways. And as our brain develops, one of the things that happen is that we build these neuronal pathways. And these neuronal pathways become our tendencies, if you will. So if I am somebody who has a negative view of myself, if I say a lot of negative things about myself, it's almost like in my brain, I'm building a neuronal pathway of negative thoughts about myself. And the more I go down that pathway, the more it becomes a sidewalk. And the more I walk down that sidewalk, the more it becomes a road. And the more I drive down that road, the more it becomes a highway. So this is how, kind of these thoughts happen for us and our tendencies happen for us. Now, these neuronal pathways are built with neurons. And neurons work because one way to think about it, right, is they move electricity in our brain. But the electricity that they move in our brain is a chemical kind of electricity as well. So it relies on these things that we call neurotransmitters. And neurotransmitters are these chemicals that allow one neuron to talk to another neuron. So in one of my neuronal pathways, I'm going to have all these neurons that connect to each other through these chemicals that we call neurotransmitters. Now, I want you to think back. For me, this is very easy because I'm a bit older. I can think back to when there were black and white TVs. And I can think back to when colored TVs first came around. And I actually can remember the first color TV that my family got. And on this colored TV, there were some knobs. And one knob, you could turn it and it would make the picture on the TV go from black to white, and the other knob, you can turn it and it would make the picture on the TV go from red to green and different shades in between. And so the first thing I want to talk about is in our brain, we have a knob sort of called contrast that can make our brain go from black to white. And if black is like nothing going on, in our brain, that knob is this chemical called GABA. It's an inhibitory chemical, and its function in our brain is to kind of slow everything down, almost like making a TV screen go black. And then in our brain, we have another neurotransmitter called glutamate, and that's an excitatory neurotransmitter. That gets our neurons really excited. It fires them up. It allows them to fire quickly. And that's almost like turning the TV screen in our brain all the way up to that white staticky, right, kind of screen where all this energy is going. It's white static, right? And our brain, we need to have the right balance of GABA and glutamate so that we can see our TV screen in our brain nice and clear. If we have too much excitement going on in our brain gets all staticky. That's kind of a manic. If we don't have enough excitement going on in our brain, if our brain is very inhibited, that's a very black or gray TV screen. That's a kind of depression. Now, that's a real big oversimplification, but that's kind of one way to think about it. But now I want to add to that we also have that other knob. It's called tint on those old TVs, right? And you used to be able to change the tint from red to green. And tint is a little bit like these other neurotransmitters that give our emotions some texture and depth and flavor. And those are neurotransmitters like dopamine and serotonin and norepinephrine. Those neurotransmitters also play a very important role in the experience of our emotions, and how those neurotransmitters balance up and down these neuronal pathways plays a very important role in the balance of our emotions. So to give you another quick picture here is a PET scan, which is one way to look at our brain that looks at the health of various neuronal pathways, if you will. And you can see in that depressed brain, those neuronal pathways are mostly blue and not very yellow. And that's a sign in this type of scan, the way it's done here, that those neuronal pathways are having a hard time lighting up. They're having a hard time activating. And that is associated with depression versus those neuronal pathways that can have the right chemical balance and they're able to easily light up, and that is not depressed. So I want to think about with you as if your brain is a machine. And as a machine, it needs the right kind of it needs the right kind of chemicals, if you will, to work really well. And this is the role of medications. Medications are to kind of help us achieve a more balanced level of neurotransmitters in our brain to help the machine of our brain work the way it is supposed to work. And depression and mania can happen because our machine components are not working well. They're out of balance. They don't have the right kind of chemical balance. And so that's one way that we can see depression. And that's one way I want you to kind of think about it. We're going to talk about another way in just a minute. So we'll get to that. But let me kind of expound on this or explore this a little bit further. So in terms of emotions, a really important part of our brain, or an important part of the pathways, is this thing called the limbic system. And the limbic system has a lot to do with our emotions. For example, we know that there's a part of our brain that has a lot to do with the emotion of fear. So if you look at this slide, there's a blue circle there called the amygdala. And the amygdala is a part of our brain that really plays a role in our experience of fear, for example. And one thing I want you to kind of think about is, just like all of us have, we come in different heights, we come with different eye colors, we come with different shades of hair. We have all these sort of characteristics that we inherit that are different for each of us. Our brains also inherit characteristics. And some people can inherit, for example, one way to think about it, again, an oversimplification, but one way to think about it is some people can inherit an amygdala that's bigger than other people. And all that means is, as they go through life, they're going to have a tendency for a brain that generates more fear than other people do. And that comes because they have this inherited characteristic in their brain that predisposes them to feel fear bigger and quicker. They have more of a startle response. And their brains are going to have a tendency to look for danger more than people that have a smaller amygdala. So if you have a bigger amygdala, you maybe are predisposed to developing some anxiety or some fears. But if you have an amygdala that's smaller, maybe even too small, you may have a brain that just doesn't generate a lot of excitement. So you may be predisposed to depression because your brain's not generating that kind of emotional energy like other brains. Now, I want to think about depression, and especially depression, but depression, we can throw anxiety in here, but I want to think about energy and depression in terms of the mood disorders. And one of the things to know is that our limbic system, which generates our emotions, you can kind of think about that generating energy. But in humans, right, we all have this very large upper cortex. And this upper cortex is where we do a lot of logical thinking. And that part of our brain, this top part of our brain, really acts like a steering wheel. So we have emotions that generate energy. That's like the motor in a car. And then we have our upper cortex where we can do logical thinking. That's like the steering wheel that helps us steer our energy. So here's another slide that shows that. You're in a car, you're driving a car. If you've got a healthy brain that's giving you the right amount of energy, you can move your car through life. And if you have a healthy way of thinking, you have healthy thoughts, beliefs, and values, then you can steer this energy as you steer your car through life in a very kind of healthy way. But what I want to get at is that our past experiences impact and influence both our motor and our steering wheel. So I've just spent a bunch of time talking about the brain as a machine, and the machine can break. And if the machine breaks, we can experience depression or a bipolar mood disorder. But I want to also tell you that you can have a machine that's actually working really well, but you can put into that machine a collection of memories or stories that now impact the way the machine works. So my brain holds inside of it all of these stories about me. So here's a picture that kind of gets at that a little bit, right? Here's, let's say, my brain. And these are actually pictures of one of my daughters as she's growing up through life. But we all have a picture of ourselves in our brain. And we hold this picture of ourselves as, almost you could take your first grade, second grade, third grade, fourth grade, take all these pictures of you and meld them into one picture. That's your self-concept, your idea of who you are. And that is contained in your brain. And that idea of who you are, with a collection of all these experiences that happen to you, that shapes the way your brain works. So you can have, as a part of your idea of who you are, you can have these collections of trauma and hurt as memories in your brain. And if you have a collection of trauma and hurt as a memory in your brain, it's going to shape the way your brain works in terms especially of mood, of energy, of depression, of mania. If you have a collection of failure in your brain where you've been given this feedback that you failed, then you have this story of yourself that has this collection of failure in it. That's also going to impact your mood. If you have a lot of loss in your life and you have this collection of loss in your brain and you're carrying around a collection of loss, that story in your brain, even if your brain is functioning very well as a machine, that story in your brain is going to impact your mood. If you have collections of manic kind of episodes, a lot of energy kind of episodes, where life got very chaotic and very confusing because you had too much energy, those memories and those experiences in your brain are again going to affect your moods going forward. So our stories and our moods are also connected, just like the machine part of our brain is also connected to our moods. All of these connect together. And this, starts to lead into sort of how do we understand what's going on inside of us? What does depression look like? What does a mood disorder look like? And I want you to think about this in terms of maybe like waves and tides and currents. So we all have times or parts of the day where we say, I'm just really depressed. I'm feeling down. I'm feeling blue. And a lot of times what all of us are talking about is what I would call waves, like the waves in Lake Michigan. We have our highs, we have our lows, we have times when the lake is still, we have happiness and joy, we have sadness, but they kind of go up and down like waves. Where we get concerned in terms of function, that I would call more like tides in the ocean. And tides in the ocean, especially when we start to see some very big tides, you can see a huge change in kind of how behaviors and actions start to happen. For example, I'm thinking of, I had the chance with my family, we went to St. John's, Newfoundland, where there is Fundy Bay. And Fundy Bay is a place in Canada where the tidal change is so big because of the way the bay is shaped, that the river that flows into the bay will actually start flowing backwards when the tide goes up. So you have a river that flows from the ocean into the land. And when the tide starts to go out, the river flows back out again. And when the tide is changing, it creates these huge waves and whirlpools and eddies, and it's very dangerous. And that kind of mood where the tide is changing and it creates these swirls and eddies, that's a kind of a manic kind of tide that we're concerned about in terms of the mood change in a bipolar mood disorder, or a low tide that is chronically always low and never comes back up in terms of a depression disorder. Another way to maybe think about that a little bit too is just kind of the currents in the ocean. And currents shape a lot of the way our oceans work, right? So there's a tropical current that flows up the Atlantic Ocean. And if that tropical current were to change, it would really change the environment. And those kind of currents can also be kind of depressive currents or hypomanic currents. And we think about depression and mania in terms of mood as more of these persistent, long-standing kind of patterns of behavior, more so than these day-to-day or hour-to-hour kind of changes of our emotions. So we're not thinking so much about waves as we are tides and currents. And I just want to put that out there because sometimes I think people get confused in terms of what depression is and how does depression differ as a clinical diagnosis from a normal, typical kind of grief or a normal, typical, expected kind of sadness. And if there are some questions too, we can kind of talk some more about that. I want to kind of now change a bit moving forward, and I want to go a little bit more into talking about kind of depression and stigma, what depression may look like in men. We'll talk about that just a tiny bit, and then in women just a tiny bit, and then children. I think one of the things that we need to talk about more, one of the things that the Momentum Center does very, very well is to really shine a light on the stigma of mental health and depression and stigma. It continues to be, these statistics are a little bit outdated, but it continues to be very interesting in terms of stigma and mental health. In terms of like people seeking treatment, right? So 54%, I don't know if that's exactly what the number would be today, but a couple years ago, 54% viewed depression as kind of a personal weakness. 41% of women were too embarrassed to seek help. We could put lots of statistics out here. This is just a handful. 92% of depressed African-American males do not seek treatment. There's a stigma there. There's a cultural belief, not necessarily a stigma always, but a cultural belief about the appropriateness even of seeking treatment or not seeking treatment. So there's lots of education that, you know, over the last 10 years has happened, but needs to continue to happen. Depression in men, you know, this is kind of interesting a bit for me because one of the things I would like to highlight here, there's lots of things we could talk about, but one of the things I'd like to highlight is that for men, depression often presents in a very physical way. And for me personally, what I see a lot in my practice is men who come in with actually back pain. And the complaint is this kind of chronic back pain. But as we kind of dig into treatment and as I work with their other medical professionals, you know, a lot of what we see is actually that in terms of what came first, the chicken or the egg, it's actually the depression that came first. And it's the depression that is expressing itself as a back pain. And that's a fairly interesting and common kind of experience. And there's actually, I can't think of the author off the top of my head, but there's actually a whole book written about this that was on the New York Times bestseller list maybe 10, 15 years ago, about sort of that somatic expression of depression in men, especially in the form of kind of back pain. But the other interesting thing for men is that emotional symptoms tend to be kind of expressed as frustration or anger or rage. And so depression can often be expressed that way in men. And anger is an outward emotion, and depression is an inward emotion. And there's a kind of socialization that has happened in the past, continues to sort of happen, that makes it difficult for males, especially, to kind of talk about what's going on inside of them. And often the feeling that gets expressed when there's distress going on inside is that feeling that's easy to express outward, which is sort of that anger and that frustration. And if I've learned that it's not appropriate to express anger and frustration, and I'm a man, the other thing that tends to happen, and again, I'm talking very stereotypically here, this isn't always the case, but the other thing that tends to happen is if I can't express anger, then I just shut down and I don't express anything, right? So it's kind of either anger or nothing. And then the other just caveat to kind of note that's interesting is that especially with males, not that this doesn't happen with females as well, but there is a tendency to kind of mask depression with alcohol. I am, as I go through these slides and I talk, I'm also mindful of the fact that I am here talking about, kind of males and females, and there's a whole new area of research that's really bubbling to the top about gender identity and mood. And that's something that I don't have in my slides, but it's certainly something that I can talk about and we can kind of discuss or comment on. But that kind of gender identity and the fluidity of gender identity and how that relates to mood disorders is actually a really important topic right now. And something that particularly as it does relate to suicide is an important piece to understand. So I talked about the back pain already here, but let me move on to kind of depression in women. And again, just a couple of interesting things here. With women, depression actually is more commonly diagnosed. Now, we don't know exactly why that is. There are some thoughts that women are more predisposed to depression because of the fluctuating hormone levels, but there are a lot of overriding thoughts that say, well, women are just more likely to talk about emotions. They're more in tune with emotions. It's socially more acceptable. And women, in terms of being smart enough really to ask for help and to help each other, create a kind of connection that allows for that sharing of information. And that sharing of information may be kind of what leads to an elevated kind of identification of depression in women, but it may very well be that there's just as much depression in men as there are in women. With women, it's just, it's easier to diagnose because it's easier to access. But the other interesting piece that gets talked about a lot is that depression in women also tends to have an anxious component that accompanies it. And what gets talked about a lot is if that is true or not. Is that really true? Or is it, again, just that men have a tendency to not express their anxiety because to express anxiety is sometimes seen with a kind of stigma as a bit of weakness. So just some kind of interesting things to throw out there a little bit in terms of depression in women, but also want to talk about postpartum mood disorder. This is getting a lot of attention as well in the last 8 to 10 years. A lot more studies are coming out about the effects of pregnancy and delivery on mood and mood experiences, and a lot more help, a lot more understanding is happening in this area. There are now a lot of centers in the last 10 to 15 years. There's more understanding, so more support available for the really the stress that a body goes through after delivery, and how to help recover from that stress, and how to help sort of recover the role that that plays on moods, and whether that's depression or a mania, or a kind of depression or mania that even can feed into what we would call a kind of psychosis, that's really seen as being very much related to the stress and energy that gets expended with pregnancy and delivery.
Brett,
Again, yes,
we have a question around depression in teens.
yes.
When dealing with depressed moods in teens, one of the things I struggle with is boundaries and expectations. You want to give them space to miss school if they need a mental health break, but is it okay to reinforce that miss school has to be decided upon prior to staying home, and expectations that breaks can occur but can't be all the time? I find it hard to know what limits and boundaries to place in teens with depression. Thoughts?
Yeah, very good. So that's actually a great segue into kind of children and depression. But let me jump along here. But let me now answer that question about teens. Um, yeah. So I think part of what you're seeing there with a teenager is a real sign, right, of depression. I'm going to skip ahead here to this sign in terms of symptoms in youth. Right there in the middle of the screen, right, missed school or poor school performance. This can definitely be a sign of depression, and it becomes a concern for a parent, obviously, in terms of helping their teenager really cope with the many stresses and challenges. And if a depression is starting to impact that teenager, you can now really feel like you're pushing your teenager, and the teenager's not going anywhere. So you're trying to push harder, and the teenager's not going anywhere. You're pushing harder. And what you may be doing is actually pushing into the depression in the teenager. That may be part of what's going on. And it's important, I think, to really be able to kind of ferret that out. And sometimes that really is an indicator, especially if there's now a pattern of missing school, to maybe ferret that out with the help of your primary care physician, or with the help of a therapist. As a parent who's got the concern and doing, kind of the pushing and feeling the concern at the level that you are, it does make it hard sometimes to be the one to sort of work with your teenager. And sometimes it's another person, another concerned and trusted person, like a primary care physician or a therapist, that can sort of have that emotional neutrality with the teenager that helps to kind of dig into what's going on a bit here. Middle school and teenage years, middle school, high school years, become a real time where an individual, our child, is developing his or her own sense of who they are separate from their parents, right? So in middle school especially, we see a lot of our children are starting to compare themselves with their friends. And that kind of comparison is happening because they're trying to kind of figure out who they are. And we have to be really careful with the healthiness of that. And how do we help our children cope with this kind of comparison that starts, because that comparison can very quickly start to lead into cliques and groups and grouping, and then, a kind of, well, how valuable is my group compared to your group? Or how valuable am I if I don't belong to a group at all? So it can really start to feed into what kind of self-concept our children are developing as they start to figure this out with their peers. And then, right, you move into high school and you have all of that going on, plus you start to have our children trying to figure out, how is it that I leave my family, right? Who am I going to be as I leave my family? Can I leave my family? Who will I be without mom and dad supervising me? And I need to become my own person. I need to kind of be without their supervision. I need to try that out a little bit. I need to see what happens. How can I do this without mom and dad watching over my shoulder? So all of that is, in some sense, sort of normal individuation and developmental kind of challenges and tasks. But helping our children navigate through that, can be a lot, right? Like going through very dangerous whitewater rapids. And, when you start to have a loss of function, in a sense, right? Like this resistance in going to school, that does become a sign that, there's more going on here, as your question kind of indicates, and we should be concerned about that. If as a parent, it's, and this can happen, I want to make sure I say this, and I want to make sure you hear this. This has no indicator on the quality of parenting, right? You can be a very good parent that's done things, has a very good relationship even with your child, and we still will see symptoms like this. It's not a reflection of your parenting. Now, that's not to say that the quality of parenting doesn't play a role. It certainly can. But I don't want you to feel like this is somehow, an indicator of your parenting, because that can make it hard to bring somebody in to help, right? And it's not an indicator of your parenting. Nobody's going to judge you as a parent. This is really more about what's going on in our children, in our child. And, it can be in very, supportive, calm homes where we have this resistance to going to school. And that can be, again, a sign of depression, but it can be, it can be the beginning of maybe a person experiencing some fear that they haven't felt before. And it may not be so much a depression as a fear. It can be a shame that has happened because of bullying, that maybe has happened because of one incident at school or a couple incidents at school. And it can be that this child is struggling with how to interpret what is going on in their environment. And, they're afraid to kind of talk to mom and dad about it, because, maybe they feel like they need to handle it on their own, or maybe they're just embarrassed by it. It can be a sign of some changes going on inside of them that they're struggling with. And again, they just maybe don't feel comfortable talking with somebody who's close to them about it, whether it's something like some gender identity questions, or whether it's something like just some self-esteem, self-concept questions, whether it is even like fears about failure, fears about who am I going to be, when I grow up. There are lots of different things that can kind of play into this. So I think as a parent, yes, I want you to be very understanding. I don't want you to come across, I would want to help you, right? Not come across as demanding or controlling, but as very concerned. And I think that, to have them stay home and not go to school can be an appropriate response if it is if this person is willing to kind of talk about what's going on and be willing to kind of engage in what's going on, and especially if it becomes a pattern. It's happened now 3 times or 4 times. If they're willing to start to talk with you about um, getting some help if that's needed, or trying some different solutions if that's needed, going to the school counselor, going to a trusted teacher, and starting to kind of dig into what's going on. um, so if you see that your child is willing to work on a solution, that's really what we're aiming for. That's the goal. The goal isn't necessarily to get them to school and just to focus on pushing them into school. The goal is to really figure out what's going on inside of them. So if they hear in your voice that your goal is to get them to school, and that feels bigger to them than the goal of figuring out what's going on inside of them, that can be part of what leads to some of this resistance. Um, and so, in these kind of particular cases, I think, getting some ideas about how to talk to your child and how to get them to talk about what's going on inside of them becomes really important. All right, so I've just kind of rambled on an answer there. That was pretty long, and I'd like to actually kind of stop a minute and see if that answer, kind of makes sense, and if there's, any follow up on that.
I'll give Angela a minute to
Yeah.
reply to that. In the meantime, we do have another question about kids from a teacher's perspective,
Uh-huh.
which is, what do you suggest when parents seem to be ignoring signs and symptoms of depression, anxiety, etc.?
Yeah. Um, the first thing that comes to my mind, and it's probably come to, sort of other minds too, is sort of um, really not being afraid to let the parent know what you're seeing, and not being afraid to let the parent know your concern, and finding a way to sort of deliver that message, to the parent, um, knowing, hopefully knowing the parent, at least maybe a little bit, and maybe you don't, but in a way that the parent can sort of hear that and hear your level of concern about that. And it may be that, um, this needs to be done a couple of times. And, I would say then, if you're not getting a response from the parent in terms of, a sense that they're hearing you and that your message has been sort of received and understood, um, I would really encourage having the student maybe talk with a counselor at school about the fact that you as a teacher are concerned, and these are what your concerns are, and then have the counselor kind of see if they can put a little bit more effort and energy into, again, sort of ferreting out um, what's going on, with the student in terms of the student's emotional health, and maybe what might be some of the factors that are playing into that. Um, yeah, and if you're um, a teacher that has a good relationship with this student, and you have a moment where you can kind of pull the student aside, don't be afraid to ask some of those questions. It shows caring and it shows concern. Um, and you know, I think most students, especially if they're in a safe environment and they don't feel like um, they're going to be embarrassed by the question. So it's a confidential kind of safe environment. Um, most of them really, really appreciate the fact that there's an adult in their life who has noticed their struggles. And sometimes all they need is just a chance to kind of talk about their struggles. It isn't so much always um, that they need a solution or they need, even advice. The interesting thing, I think, for a lot of teenagers is they have so much going on sometimes in their thoughts that it feels like, it's just a knot of thoughts. It's a ball of thoughts that are kind of all wound up and they can't, it feels like they can't kind of make sense of it. It gets very confusing for them. And if they have some time with a trusted adult to just start to talk their thoughts, and maybe even kind of write their thoughts, what happens is in their brain, it feels like there's this confusion that's kind of like a thick fog everywhere. But as they start to talk it out or write it out, it feels like they start to get their hands around it. It feels like they can start to grab some of it and hold it. And it feels like it starts to maybe make a little more sense to them. And as that feeling of, I can hold this, as they start to feel like they can hold it, their level of emotional distress goes down. And oftentimes, that's all they need is for that level of emotional distress to go down. And oftentimes, what just brings that down is this sense like they can finally put their hands on it. They can finally hold it. Right?
Okay. Are we allowed to ask questions?
Sure.
Yeah, let me get one that's already in the chat a minute, and then we'll
Uh-huh.
come back, Kristen. One
Okay,
in the chat.
I couldn't open this meeting. I mean, it's taken forever for me to be able to get into this. I had issues connecting, and I'm glad I did, but it's halfway through, and I feel like I missed a whole bunch of stuff. But
It has been recorded, Kristen, so I can make sure that you get the recording.
okay.
Okay. So just ask for clarification here. Could you clarify your statement in regard to men and their expression of emotion? Does the study show that men will tend to shut down if they're not able to express any emotion by way of anger, lashing out? Or did you mean men will tend to shut down if they do not feel comfortable expressing emotion in general? Sadness, fear, grief, worry, just for what it is.
Yeah, again, there are a lot of exceptions to this, but in general, emotions are uncomfortable for men, especially inward emotions. So the emotions listed there: sadness, grief, shame. Those are all kind of inward emotions, and inward emotions create a kind of uncomfortableness in general, right, for men. And so there tends to be a kind of, I say shutting down, but it's kind of, it's not wanting to go there in that sense of a kind of shutting down. Because you could have a man who's very talkative, but is talking about, whatever their interest is, fishing or their gardening or whatever their interest is. And they're very willing to be, very open and expressive about the interest, but they have this real avoidance of more of those kind of painful emotions because there's a real uncomfortableness in expressing them. And that can lead to a kind of distance in relationships if we're not able to express and communicate our emotions to each other, especially more even those hurting kinds of emotions. If we can't express them to each other, it does create a kind of distance in relationships. And if we can feel safe enough and develop skills for expressing and hearing those emotions, then the depth of relationships, really starts to deepen and starts to grow. So, yeah. So, anger is just a very easy emotion to express. And it's also socially very acceptable in some ways for males to express anger. So that was really the the point I was trying to make, is that anger is an easier, more socially acceptable emotion. And there are men who have a tendency to be able to sort of express anger very easily, but not any of the other emotions as easily.
Oh, we did hear back the question about the child in school. She agreed that school is not the main issue, finding out what's going on and how to help is. And then she concludes with, I know as a parent, the long-term need to have coping skills to rely on to make it through depression when our kids become independent is so important. So I just wanted to recognize your contribution, Angela. Um,
Let me actually just add one piece to that,
sure.
which might be very helpful and interesting too. Is there's been a movement again in the last, I'll say 10 years, maybe it's been 15 years, uh, away from um, away from kind of what we would call sort of self-esteem building into what we kind of call self-care or self-compassion. It's actually known as self-compassion. And it takes kind of the idea that oftentimes, and a lot in the past, 20, 30 years ago, what was kind of done was to sort of help kids compare themselves to others in order to find out what they were good at and then build their identity around what they were good at. But what research began to really uncover is that as we were teaching kids and teaching ourselves to compare ourselves to others, we were actually creating a skill that was helping kids feel sort of less than. And there are Brene Brown and some other authors. There's an author, Krista, I can't think of her last name now, out of the University of Texas, that have really done a lot of studies on self-compassion. There's a very good TED Talk on self-compassion. And self-compassion really kind of teaches our kids to think about themselves as a bank account. And we teach them skills for investing in themselves, not so much skills for comparing themselves to others, but skills for how to invest in themselves. And as our kids learn to invest in themselves, they build a sense of healthy self-value. And so this TED Talk on self-compassion is a great introduction to kind of thinking about how do we help our kids and our teenagers think about how to invest in themselves and how that helps to build a kind of resilience. And it really also plays into cognitive therapy for depression, because we're teaching, instead of making those negative attributions about ourselves or about the future, we're learning how to invest in ourselves and how to grow some positive attributions about ourselves and how to be sort of hopeful about the future because of that. So look at that piece on self-compassion.
Thank you, Brett. Kristen, if you want to go ahead and unmute yourself and ask your question.
Well, I suffer with depression and have for many, many years now. The issue that I'm having is that I'm not getting a lot of like family support, like the emotional support. I suffer with anxiety. I suffer with PTSD. And
Yeah.
are there ways? My biggest thing is I'm fighting with my mom and dad currently. I'm 47. I live by myself, and whenever they talk to me, whenever it's anything about me, it's all negative. It's all put downs. It's all, I don't know. They
Mhm.
treat my brother's family like gold,
Mhm.
but when it comes to me, because of my issues, I'm treated much worse. And I don't know how to make them realize that that putting me down, calling me names, not caring about what's going on with me in the moment when I'm at a low point, instead of criticizing me and calling me names and putting me down, they could come up with better ideas as, you know,
Yeah,
they could be a whole lot nicer than they are. And
yeah, yeah.
I
Kristen,
don't
you,
know how to change that.
yeah, you raise a really, really good point here, a very good issue, which is that, one of my, I'm probably kind of known a little bit for saying this phrase. I don't know if that's a good thing or a bad thing, but I'll tell you what this phrase is that I'm kind of known for, because I do share it a lot with the patients that I work with. But one of the things that I come back to a lot is this phrase, that we live in a broken, messy world. And we all want to fix this world. We all want to make it right so it's not broken and it's not messy. And unfortunately, for some of us, many of us, that broken messiness really does find its way into our families. And um, we want so much to kind of clean the world up around us, right? We want to try to fix it. And what happens is, we put a lot of effort into trying, to sort of clean up maybe our even say the front yard of your house. You're working very hard to kind of clean that up. But if every time, let's say in this case, sort of your parents drive by, they throw their garbage out onto the front yard of your house, then you can clean and clean and clean and clean, right? But unless you get your parents to stop that behavior, you're going to have to keep cleaning, right? And here's
Exactly.
here's what happens is that we have to kind of come to the realization that we can't change other people. We can ask them to change, but we can't change other people. And the pattern that I see that happens a lot is, if my parents don't understand how much I'm hurting, then I have to make my hurt more apparent to them. I have to try to make my hurt more understood by them, more easy for them to understand. So people start to put a lot of effort into communicating their hurt to somebody, trying to let them know how much they're hurting. And that actually can really create a lot of um, despondency, a lot of despair, and a lot of feeling like you're being ignored or pushed away. Because if you make your hurt bigger and your parents still don't see it or understand it, then you're going to feel smaller and less important and less significant. And if you keep trying to make your hurt bigger, right, then what happens is you kind of get focused on making your hurt bigger, and it hurts even more because now they're not paying attention. And so one of the things that often happens in therapy, and Kristen, this may not be the answer you're looking for, right, but is this thing that in DBT therapy, which is a kind of therapy, is called radical acceptance. And it means getting to that point where I have to accept something in a really big way that I don't want to have to accept, maybe. And I have to learn how to accept it and live with it the best I can, because it's a broken, messy world. I love, you know, I used to read Ann Landers a little bit every now and then. I don't know why I always did that, but I used to read columns like Ann Landers. And one of the things that Ann Landers often said to people is, your family sometimes has to be who you make it to be. And it may be that for you, the emphasis is not going to serve you well to try to get your parents to understand you with more effort. But it may be that you got to take some of that energy and really start to maybe focus on um, finding some friends that can be really understanding and supportive of you, and help you with some of that self affirmation and self validation.
Absolutely.
Yeah.
I was doing a DBT course through Pine Rest, but I had to stop doing that because I moved over to Ottawa County Mental Health.
Yep.
And
Yeah. So, there are some very helpful DBT resources online. So I'll point you to those tonight. Um,
great.
but there may be some DBT groups in the Holland area as well. I'm not sure. Yep. But there are online some very helpful DBT support resources.
Wonderful.
Yeah. Thank you. Good question. I'm kind of almost done with my slideshow here. So we've got these kind of depressive symptoms in youth. I think the interesting thing here to note is that it is interesting to kind of look back over the last 10, 15 years. The group that is getting prescribed antidepressants the most in terms of the percentage of increase is actually children, right? Children are being prescribed antidepressants at an increasingly bigger and bigger rate. And then, the effects of depression on families. And here I'm focusing especially on families of depressed teens. I think that bottom point maybe is very interesting, which is that the depression of a teen and the depression of a parent can really start to play off each other. And maybe one kind of point to make here is sometimes in therapy, one of the most important things we can do is to learn how to hear somebody differently. And what I mean by that is oftentimes what happens, I see, is parents who are very concerned can start to give suggestions to their teenagers. And those suggestions are given with a heart that is very, very filled with very good intentions and wants to be caring and wants to be helpful. But what happens is that our teenager hears the suggestion as kind of advice that they didn't do. Here's a suggestion, and some teenagers say, they think to themselves, I should have done that. I didn't do that. Now my parent has to tell me to do that. I didn't do it. I must be a failure. I must be a failure because I need suggestions. I need somebody to help me. And so, what happens is that a teenager especially, can fall into this pattern of hearing what we're trying to say to them the wrong way. Instead of hearing it as encouragement and help, they tend to hear it as criticism, like that suggestion is critical of me because I needed the suggestion because I didn't do it. Or sometimes we can get to the point where we say our suggestions and we have a little bit of a tone of frustration in our voice, and that little tone of frustration can make that suggestion feel critical. So I think, where the teens and parents can play off each other, especially if there is some depression in the family, that's one area that I'll just kind of highlight tonight as an area to kind of pay attention to. That always remember that what we say and how we're trying to say it may not be what's heard and how it's being heard, right? And we have to be able to kind of ferret that out and get to the root of that and talk about that and create an understanding around that. So, boy, I went through a lot tonight. I feel like I did a lot of talking. I hope that it was helpful, but I think maybe at this point, what I'll do is kind of turn off the screen share, and maybe we've got time for a few more questions or some comments, and then we can wrap up this evening. But thank you so much for coming, and thank you so much for listening. I really appreciate that. And and thank you, Barbara, for the Momentum Center and for the chance to do this.
Oh, so grateful, Brett, for all of the information you've shared, for taking the time to do this. If anybody does have any final questions or comments, please just indicate with the raised hand, and I'll ask you to unmute yourself. Oh, Kristen, did you go ahead and make another comment?
Um, I don't know how typical this is for depression to run on like my mother's side of the family, because my mom's mother was always so negative and nasty and critical of my mom, but she babied my mom's sister. And my mom has a very short temper and a very short fuse. And if and when I say or do the wrong things, it's like whatever I say or do is wrong. And I'm beginning to wonder if my mom is bipolar, but she doesn't understand that. And that's why I have depression, because it's hereditary.
You know, Kristen, certainly mood disorders definitely have a hereditary component to them. But what I'd actually like to focus on with what you said is I'd like you to really kind of focus on the fact that you have this awareness and you have this insight of, you know, what this pattern has kind of been in your family. And I'd like to encourage you to really use your awareness and your insight as a filter with which you can kind of hear some of that criticism, so that, you know, it can help you kind of mute that criticism, or maybe even be a bit of a force field to help that criticism not stick to you, because you can kind of see and understand it as a behavior pattern, or a pattern that's kind of gone on in your family. So while depression or that mood disorder could certainly be hereditary, I want you to kind of walk away with that understanding that, you know, you have been able to kind of see that, and seeing a part of that pattern can actually be something that really helps you. So I want you to kind of focus on using that in a very helpful way. Yeah,
Yeah, exactly.
very
Thank
good.
you.
You bet.
Ben, you had a question or a comment? Go ahead and unmute. There you go.
Hi Brett. I got a question.
You bet, Ben.
I was wondering, like, with depression, do you see a pattern of people being more withdrawn with depression, or like does it vary in people basically?
Yes, you know, there is definitely a pattern of withdrawing more with depression. And that's one of the signs of being depressed, is that that tendency to kind of withdraw. You know, Ben, what's interesting about that is um, one of the factors that's important in depression is this sense of loss, or the sense of not having something. Um, and whenever we have a sense of loss inside of ourselves, or a sense of emptiness, right, it produces in us a kind of response where we sort of withdraw. One way to kind of think about it, as it's almost a kind of circling of the wagons, because if we feel a sense of loss, or we feel a kind of emptiness, we also tend to feel a little more scared or insecure. And so that withdrawal is it's a protective response often. And so we're trying to kind of protect ourselves. The problem with depression is that depression creates a kind of withdrawal that's a constant withdrawal, where we're always withdrawing. And so the very thing that we're doing to protect ourselves ends up hurting us, because we're withdrawing from people more than we should. So it's one of the interesting things with depression, is sometimes we have to teach people how not to withdraw so much, but withdrawing can actually be a form of protection. So it's almost teaching people how to set their protection down. And that's scary, right? Anytime you set your protection down, it's very scary. And that's one of the challenges of treating depression, is kind of teaching people how to set that how to be scared and set that protection down. So yeah, absolutely. Good question.
Thank you. Any others? Well, again, Brett, so grateful. This has been so helpful. And I want everyone to know that we have been recording this. We'll put it on our website, our YouTube. I want to invite you to return next week, and as we talk about panic and anxiety disorders. And also, Brett has agreed, as have our speakers, that once we get through COVID and things start opening up, that we'll also have an in-person spring or summer series, and have an opportunity to engage in this conversation in person. So thank you so much, Brett, for everything that you do to create a healthier community. So grateful for you.
Thank you. Thank you everyone for being here. It's been a pleasure.
It's wonderful information to have.
Excellent. Super. Take care.
Thank you.
Bye.
Good night and namaste.